Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Brian Waterman, a shoulder and sports surgeon at Wake Forest, North Carolina. Brian, how are you?
Hey, Peter, doing great. How about yourself?
Oh, I'm doing great. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, Wake Forest University, or the institutions of any of our guests. Today we have a very exciting episode on the evaluation and management of the Hill-Sachs deformity and glenohumeral instability. This continues to be a source of fascination and variation in treatment among shoulder surgeons, and to discuss, we've invited two nationally renowned experts. First, from Pittsburgh, we have Dr. Albert Lin. Albert, welcome to the podcast.
Thanks so much for having us. Really excited to be here.
Oh, we're very excited to have you. Next, from Mississippi Sports Medicine, we have Dr. Larry Field. Larry, welcome to the podcast.
Thank you, Peter, and thanks for the opportunity.
All right, so let's start at the beginning. So between 1832 and 1930, there were several case reports of this common defect in patients undergoing humeral head resection for chronic dislocation, but it wasn't until 1940 the two prominent radiologists, Harold Hill and Maurice Sachs, published their landmark paper describing this pathologic region and the mechanism for injury associated with glenohumeral instability, and they had actually a series of 119 patients. So fast forward to today, I want to start with you, Larry. How would you define the Hill-Sachs? When you see this, what does it mean to you when you hear that term?
Yeah, I mean, the Hill-Sachs is, I guess, one definition to be an impression fracture of the posterior humeral head that occurs as a consequence of being, I guess, for lack of a better word, impaled by the anterior glenoid rim in a patient who has a dislocation. It's pathognomonic for a dislocation. And so that's how I would define it.
Yeah, Albert, maybe I can follow up on that. Larry, you've alluded to the spectrum of disease, and that can be anything from just a bone marrow edema lesion to something that's truly a frank osteochondral fracture and impaction. And so there's some variation that we often hear quoted regarding the prevalence. Albert, what do you quote to your patients, and maybe do those numbers change depending on who's in front of you?
Yeah, I mean, I think what Larry mentioned about that being pathognomonic is sort of the key. We see a lot of patients who describe some episodes, but then if you see nothing, like on the back of the humeral head, and you see sort of nothing on the labrum, you're sort of stuck wondering whether they actually had an event. And so I agree, there's a big spectrum of, what you would call just either some signal in the back or an actual, I actually tell my residents a Hill-Sachs gone wild actually creates a greater tuberosity fracture. So yeah, there's a big spectrum of it, but I think it's key to even see changes, because then something has happened. So essentially, I would tell most of my patients that it's not 100%, but you're getting close to 100% if you have a true event, in my opinion.
Now, you mentioned imaging along the way there. Certainly we can see this on x-ray, but I think at this point pretty much everyone is using some sort of 3D scan. So Larry, what's your preference here? If you were to try and image just the Hill-Sachs, do you think MRI is better? Is CT better? And in resource-limited environments, are plain x-rays enough? What are your thoughts?
Yeah, I don't rely on radiographs to make any determinations about Hill-Sachs dimensions or size, but it depends on from a research standpoint. I think maybe one might argue that 3D CT scan or maybe an MR arthrogram might be the best tool to best define the lesion. But in a clinical setting, I think that may be a little different. Like for me, in a clinical setting, for most clinical settings, we just obtain an MRI to evaluate both the glenoid and Hill-Sachs lesion, because we're typically just trying to evaluate what intervention we may or may not entertain, especially in a patient who we don't suspect is having critical bone loss on the glenoid side or a very large Hill-Sachs lesion on the humeral side.
Yeah, Albert, maybe we can dig in a little bit on that. We're talking about the characterization of these lesions, and a lot of times it merges between more objective measures, things like the Hill-Sachs interval and the glenoid tract or the distant dislocation. But I'm curious, when you look at these Hill-Sachs lesions, how do you quantify or characterize this lesion in a real reproducible way, at least one that influences your clinical decision making?
Well, I mean, I think you're getting to the sort of the heart of how do we make these measurements to determine what we think is the best way of maybe evaluating them objectively right now. And I would say that, that you kind of alluded to sort of this near track, off track, sort of on track deficit. And I think there's a lot of variability how you can measure this, right? MRIs give you detail, but they may miss certain cuts. CT scan, you might get sort of, we're often trying to make some 2D measurements from, what we know is a 3D lesion. And so for me, I think and this may or may not be right, but we usually just try to pick the largest deficit that you would see on an axial sequence and basically be able to measure your Hill-Sachs interval that way. But there are some nuances, right? Because the Hill-Sachs can be superior or inferior. It can matter where it is located on the humeral head. And so I think this whole concept of trying to do a 2D measurement on a 3D structure is limited. And I just don't think right now that's the best way that I would say I could do it. But I really think that there are some limitations in our ability to characterize this accurately from a 3D standpoint.
Albert, I couldn't agree with you more that it's so challenging to know how to make those measurements accurately. One of the things I wanted to ask you about specifically, because you've done so much great work on this whole kind of distance to dislocation concept, which I think is somewhat based on the Hill-Sachs, but of course also based on what's happening on the glenoid side. When you make your measurements, I just want you to think for a second about the idealized world. In what plane would you want to make them on the humerus? Would you want them to be orthogonal to the cuff? Would you want them to be as wide as possible on the lesion? Would it matter what the patient's range of motion look like? Like, tell us how you would, when you make that measurement, what in the ideal world would it look like on the humerus?
Yeah. I mean, if I had a perfect way of being able to measure this, it would be like a dynamic measurement where you could put somebody into sort of, sort of the motion of getting them into ABER and seeing them fluidly move and sort of how they're articulating on the humerus as they move. I know there's no real way to kind of dynamically measure that right now. But I would say sort of an ideal sense, that would be what you would do. You would measure a 3D structure dynamically. However, I think right now, probably, and I don't know, you guys may all have different ways of measuring this, but for me, you kind of take worst case scenario. And for me, that's essentially an axial sequence looking at sort of the medial lateral dimension, which probably matters a little bit more than probably the cranial caudal dimension. We've also done some work looking at that too, showing that sort of the more inferior Hill-Sachs lesion is, the more I think worrisome it is. And it may make some sense because in those positions, your arm just has to be in adduction for potentially Hill-Sachs to engage. So I think there are some limitations, but for now, I think we use the worst case kind of scenario measurement.
Yeah, Larry, I feel like sometimes this is considered on a binary scale, right? Presence or absence of Hill-Sachs lesion. But as you know, and as Albert has alluded to, it's the medial lateral distance, proximal distal distance, it's the depth, it's the surface area, whether there's any articular cartilage on the other side, i.e. that little strip that's kind of more centrally in the head. What do you find are the most important factors for you as you're considering this and trying to lean on a specific aspect of treatment?
Yeah, it really is for me always in conjunction with what's going on the glenoid side. Now I've seen, relatively large Hill-Sachs lesions in the complete absence of glenoid bone loss, but at least in my practice, that's very uncommon. So we really don't evaluate the Hill-Sachs lesions in isolation. We always evaluate glenoid bone loss. We always try to assess the glenoid tract to try to determine in a more global way how we might make management decisions on behalf of the patient.
Let's get into management. I think that's really the heart. So you've made your measurement, you've determined your width of the Hill-Sachs, you've determined your distance dislocation, you've seen what's happening on the glenoid side. Let's talk first about when you can leave this alone. So tell us, Albert, is there a Hill-Sachs that we can leave alone, or are you always addressing it? Who are the patients where you would say this can be left?
Yeah, I mean, it's a good question given sort of all the popularity of Remplissage. It's hard to go to a meeting now where you don't see essentially everybody saying you should Remplissage something. But I always kind of feel like in ortho, right? When we go into sort of all or nothing kind of categories, there's always something that there are consequences of doing things, right? And so I would say I'm much more aggressive doing Remplissages, obviously, but we've been trying to determine. Larry was kind of alluding to this. I mean, you can't you look at the Hill-Sachs as one part of many sort of factors, of which glenoid bone loss obviously is a huge component of that. But there are also other factors that play a role, and you start looking at sort of demographic risk factors in addition to anatomic ones. And so we look at things like, the age of the patient. Do they play contact sports? Have they had prior dislocations? Do they have some component of hyperlaxity? And I think all of those factors determine sort of your risk threshold for when you believe a, remplissage or something else to address the Hill-Sachs is necessary. And so we've been sort of trying to develop a risk assessment score to kind of look at these factors. And essentially that boils down to this. I think if they have almost none of those risk factors, so they're an older patient, they have, minimal glenoid bone loss, they don't participate in competitive sport or contact sports, they haven't had a lot of preoperative dislocations, and they have no hyperlaxity. I think those are people you might be able to consider, a standard Bankart approach and without having to put a remplissage. But I think once you start getting into some of those risk factors, remplissage, I think, becomes much more protective. And then we also know that if you have way too many of those risk factors, that probably if you try to force it with a arthroscopic approach or with remplissage, it'll probably be unsuccessful. So, I think there's a need to determine sort of how maybe AI will play a role in that in the future too, where you can kind of input all these factors and kind of see where probability of success is. But I think those are the risk factors that sort of we look at to try to determine if a remplissage is necessary.
Yeah, that's great. I think what you're suggesting is there's a fair amount of nuance in this area. Certainly, many of our European colleagues, our international friends, they would talk about the supremacy of the bone block. There's another faction of our colleagues that might suggest that remplissage is gaining ground again. Pat Denard suggests that it's comparable when compared to Latarjet. And so I'm curious, Larry, who do you think is the ideal patient for remplissage? And certainly you can factor in your glenoid-based treatment, but who are you performing that on classically today?
Yeah, it's I appreciated Albert's comments about how important it is to individualize treatment decisions in patients with instability, and all the factors that he mentioned. I completely agree go into that calculator that we use to make treatment decisions. But I would argue that I'm really in the remplissage camp. I've used it liberally for many years, and for us, in a patient, and it's based on work that a number of authors, systematic reviews, et cetera, have demonstrated, I would argue, very consistently, and that is that it dramatically reduces recurrent instability rates, and that there's marginal, if any, external rotation motion loss. There are a few studies, but by and large, and for example, even on the study that there are a couple of studies that Pat Denard and his group have recently published comparing, and just this month in AJSM, his group reported on a systematic review of 27 studies, I think over 2,000 patients, comparing Bankart remplissage with both isolated Bankart and Latarjet, and there were no differences in external rotation, for example, in any of those three groups. And so I think that for us, and it's been our experience as well, that remplissage is a tremendous improvement. We see very little risk of using it and are quite liberal with utilization of it. I would agree with Albert. There's some occasional clinical situations we might not do it in the face of a remplissage, but for us, if there's a remplissage in a recurrent anterior instability patient that we have elected to do an arthroscopic procedure for, we are very inclined to do a remplissage at the same time.
Now, Larry, I agree with all that, but the concern I always had is one of the things I learned in residency is there's no free lunch. There's nothing you do that doesn't have potential downsides. So I hear you that there's not a lot of loss external rotation, and you haven't seen a lot of complications, but there has to be some downside. There has to be some reason not to do the remplissage. So tell me, have you seen any complications specific to it? I mean, I've certainly seen some. Do you think there's a downside in the future that maybe we haven't appreciated yet? I mean, is it possible this contributes in the long run to cuff tears? Tell us what your thoughts are.
Yeah, it's a great question, and I think that's been one of the reasons that there's a wide variation in how often surgeons use the remplissage. I have personally not seen any complications, and we've been using it for 15 years now, and there are several, at least 3 long-term studies that I'm familiar with. One is, I think, by Batard, and it had a minimum 10-year follow-up and found no complications. There's been this concern potentially that it could affect infraspinatus function, but Marola and others have shown that it didn't in comparison with side-to-side strength and ultrasound filling. So who knows? You may be right, but I would acknowledge that it's been around for a very long time now. It was published, I think, initially in 2008, and I've been using it personally for 15 years. So I think maybe we'll be surprised one day, but it's been a long time when you think about it in terms of what we do anything either arthroscopically or open.
So let's dig in on technique. Albert, I'm sure you and I are both students of the game. We've watched Larry's videos. They're immaculately done. There's absolutely zero bleeding. He's shown us his blind tying technique and just its mastery. I'm curious, what technique do you use for performing remplissage today?
Yeah, so I mean, I totally agree. I mean, it's somewhat intimidating actually to be even on this podcast with Larry, to be honest. But the technique that I use is an all intra-articular technique, and essentially what we do is just we sort of back out our cannula right to the level of the capsule, and if typically you can actually kind of see sort of the infraspinatus capsular layer, and then we use essentially a double pulley technique where we kind of punch on each side of the capsule within the cannula. You can do this either through a bridge technique with like a knotless sort of mechanism, or you can just tie it using a double pulley. And so essentially that's what we do. We really try hard not to get much of the infraspinatus, and I think what we end up getting is much more of a posterior capsular type tenodesis rather than the sort of a entire infraspinatus that you can often get if you do perk anchors. And so I would agree with Larry, since I've been more widely adopting it over the past, I would say 5 to 7 years, I would say. I have really rarely seen patients of ours that have a lot of external rotation loss, and I think it may be due to the fact of essentially getting mainly the posterior capsule rather than the infraspinatus.
Yeah, certainly, Albert. Sage words, and I agree with you. I was kind of a late adopter, mostly because I was really concerned about some of the range of motion loss, but I agree with you. And so I wonder if this wouldn't be a perfect time to drill down a couple key concepts. Can you comment on the safe zone for instrumentation, the so-called remplissage safe zone, so that you capture the capsule and tendon rather than getting into the muscle and doing a myodesis in effect?
Yeah, I mean, people talk about if you go too medial, you can essentially capture the muscle sort of tendon junction, which is probably what Peter was alluding to. If you can see sometimes, I'm sure if you do that too medially, you may in fact get potentially some myotendinous tears. To be honest, if you sort of kind of spot weld that area, so if you're kind of lateral. And you can clearly see after you back out or sort of spin your cannula back, the capsular junction. It's very unlikely, honestly, that you capture a lot of infraspinatus tendon or the muscle. And we do sort of a sweeping maneuver as well to kind of try to sweep some of the muscle off. So I would say, the tricky thing then becomes, though, and we could, I'm actually curious what you guys do in particular, and Larry, is when the Hill-Sachs gets pretty medial, it sometimes becomes hard to know exactly where to put this anchor. And some of us would say, okay, if you put it way too medially, maybe that's a situation where you might get some kinematic changes and potentially in fact capture the myotendinous junction and sort of that unsafe zone you're talking about, Brian. So I'm very curious, when you have a very medial based Hill-Sachs, sort of where you guys are putting your anchors.
Larry, I'd love to hear your thoughts here on anchor position, but also maybe number of anchors, soft versus hard, knotless versus knotted. Do any of those factors matter here? What do you think, Larry?
Yeah, it's a great question because, sometimes, these Hill-Sachs lesions are quite medial and makes one uncomfortable because typically in most of these, for example, on-track Hill-Sachs lesions or whatever, we'll put the anchors along the new articular face in an effort to maybe reduce the risks of engagement due to soft tissue interposition. But in large, more medial lesions, often we want, because I actually anecdotally don't have any real data to suggest this or prove it, that the check rein effect is more important than filling the most medial aspect of the Hill-Sachs lesion. Garcia and others have demonstrated that the Hill-Sachs lesion remplissage does reduce antitranslations and positions the humerus more posteriorly and inferiorly in positions of risk. So I just think that the check rein effect is important. So, for example, if in a very medialized Hill-Sachs lesion, I'll often not put the anchors there. I'll put it more in the valley or even more laterally than that, depending on the clinical scenario. But I always use remplissage in that setting where I'm doing arthroscopic stabilization because I worry about that and it gives me comfort. And we found it to be quite valuable even for large medialized Hill-Sachs lesions.
Larry, it's awesome that you mentioned that because that's what I do too, and I just wanted to make sure, like the expert, the expert that does this is the same way that I'm doing it. I actually, I'll for those really medial based ones, I don't go up to the articular margin. I'll go sort of to the valley, but I don't really have much proof that that's the right thing. But I agree with the check rein effect for sure.
Yeah, we know George Outwall, published a study a number of years ago where he, in a cadaveric model, created Hill-Sachs lesions and put the anchors either most medially or in the valley or laterally. And in his cadaveric model, he found motion loss for all three of those most medially. And we haven't really seen that translate into clinical studies, but I think it does make sense. It is logical, and we try to avoid it if we can.
Yep.
It's a safe space, Albert. You can share your opinions liberally, I promise. Larry, I'm not going to let you off that easy, though. I want your top two pearls for efficiency and reproducibility of your remplissage. What else can you share with our audience?
Yeah, it's a good question. I use the same posterior portal. I don't make an accessory portal, but because I use a knotted technique, I can bring a retrograde retriever in more laterally, into that defect, again, to avoid too medial of a position with our interposition or capsulodesis. So that's one trick. The other is that we've looked many times arthroscopically to watch the posterior capsule feel that defect when we tie blindly. And we've looked in the subacromial space to see where our sutures are. And we just do a blind tie technique. As Albert alluded to, we kind of back up, we screw backwards the cannula and tie mainly the capsule. And we've not had any problems with that. I don't feel compelled to look or worry. It always feels it. And so I think whether you do a knotless or a knotted technique, you can count on the capsulodesis, the capsule interposing. I do abrade the Hill-Sachs lesion, again, to stimulate it as well. But those are really the only tips. It's pretty simple and pretty straightforward. And I use one or two anchors depending on the size and orientation of the lesion.
Right, so I wanted to move on to even bigger Hill-Sachs. So when is it appropriate to do a graft or an arthroplasty? So sometimes, these lesions get very large. When do we need to add back in bone, cartilage, metal? When do you start to consider this? Is that based on percentage of the articular surface, dynamic assessment, some other factor? What are your thoughts, Albert?
Well, I mean, I think it's who knows what the magic number is, right? I think most of us probably have somewhere roughly around, if it starts involving more than, let's say, 30 to 40% of the humeral head, we start thinking about whether or not soft tissue is enough. I think for me, one of the keys is understanding if you have like a bipolar bone loss issue, and you're able to reconstitute, let's say, the glenoid with a bone graft, and you still have a very large sort of off-track Hill-Sachs lesion, I start to really wonder whether or not just simply restoring sort of a soft tissue type tenodesis is going to be enough. And that's probably where I would say I would worry when there's so much bone loss that even if you reconstitute the glenoid, that there's still a significant issue with sort of the Hill-Sachs. And usually, I think that probably amounts to somewhere between 30 to 40% of the humeral head missing. I think what I was thinking about when we were just chatting about this just right now is if there's an easier way to bone graft the humeral head, like an arthroscopic reproducible way to bone graft the humeral head, it may make a remplissage sort of obsolete, because that's truly restoring anatomy. But I think until potentially we get to that point, probably, I know sort of a wishy-washy answer I just gave you guys, but I would say once it's heading upwards north of 40% of the humeral head missing, I'm doubtful that remplissage can really be protective.
And Larry, is the number the same place for you, 30 to 40%, or do you have another way of making that decision?
Yeah, it's another good question. And I think what Albert alludes to again is how especially these complex cases have to be individualized. I mean, the glenoid side matters a lot in a situation like that. It's very rare, again, that you would see a very large Hill-Sachs lesion, like 30% of the articular surface, that doesn't involve significant glenoid bone loss, and the age of the patient, whether they're actually unstable or not. And so I think those things really matter. I think for me, and I've done a few times in my career where I've done a remplissage combined with an open lateral. I'm a sling guy, and so it's not difficult to do the remplissage, just to braid the Hill-Sachs, put the anchors in, and put them aside, put the sutures aside to the end of the case, and do your lateral and tie it at the end. So that kind of combination has worked for me before. And so I think that you can combine a soft tissue procedure with a bony procedure in the front. And certainly you can do it arthroscopically with bone blocks and that type of thing. So again, it's highly individualized. Is it a seizure patient? Are the seizures under control, et cetera? But I think 30%, especially with instability, recurrent instability, is a really trigger for me to do something very significant.
Yeah, it's funny, Larry. I will say the only time I've combined the two is in a seizure patient that you're describing with glenoid bone loss, maybe even upwards towards 30% humeral bone loss, because the lateral is so powerful. And then I need something else to kind of supplement the sort of the recurrent seizure disorders. And so that is probably the few instances I've kind of combined the two that you're describing as well.
Right. And Pascal Below published a study last year, I think in ASES, where he talks about really big Hill-Sachs lesions, and several of those patients were seizure patients, and he combined an arthroscopic lateral with remplissage.
Yep.
Yeah, Albert, these are one-off cases, right? And there's not a ton of data out here. What's your technique for grafting? Is it, relying on some snowman plugs? Is it an oblong graft? Are you kind of doing an orange slice technique? Is this mostly through the front? Maybe walk me through your thoughts there. And then what we'll dovetail into is just a discussion about doing both sides. How do you accomplish that?
Sure. Yeah. I've done a few of these cases, obviously. I've always done them open. If I bone graft them and essentially do essentially a complete arthrotomy approach from the front, and essentially externally rotate just like you would in a total shoulder. I use a lemon slice technique, something I learned from JP Warner in fellowship, was kind of cutting a zero form, basically using a piece of zero form to kind of cut a template, I guess, for the missing Hill-Sachs on the humeral head of the patient, and then taking that piece of zero form on the back table and laying that on top of essentially laying that on top of the graft, and then you can kind of outline it with your marker, and then you can essentially just cut using a your saw to get a lemon wedge, and you can obviously shape that a little bit to fit it better, and then use countersunk screws, and so 2 or 3 depending on sort of the size of the defect, and usually kind of a nice way to sort of match your defect.
Larry, any additional thoughts? What about when doing concomitant procedure? I heard your allegiance for the remplissage still when doing glenoid grafting. Is there ever a scenario where you would do a humeral-based reconstruction in addition?
Yeah, I've done that twice in my entire career. It's been very uncommon for me, but I think it brings up a point too about the different practice profiles that surgeons have. Albert has tremendous practice. He sees quite a number of complex problems. I, on the other hand, I'm more in a community practice. I see a lot of kind of typical traditional index problems. And so for me, that'd be a very uncommon intervention. But that said, I've done it twice, and I will call Albert the next time I need to do that so that I can get the details on his wonderful technique.
Yeah, I certainly don't want to get into a referendum on whether Southerners do more crazy things than folks in Pittsburgh.
I will say, Brian, there's one case I had actually very early in practice. It was a locked anterior dislocation. The guy had been locked out for about 4 months, and we did. So he had about a 40% humeral defect, and he was youngish. I think he was in his 40s to 50s in Carpenter. And it actually had a very difficult time getting from the front to graft it, because it was, because of the location of it, and sort of, even if you could make that, it wasn't difficult to match the defect with the graft, but it was difficult to get sort of a screw trajectory to drill. And so I ended up actually making a separate approach posteriorly, through a posterior window, which actually gave me direct access to the back of the shoulder. So it's the only time I've really ever had to do that for this type of reconstruction. But in case of a bailout, that is an option to essentially split the deltoid, split the infra, and then kind of do an arthrotomy in the posterior capsule, and you're sort of right onto the back of the shoulder. But I have not grafted these arthroscopically. I know people are starting to describe that and potentially using the talus. I am very intrigued by those techniques.
Yeah, Larry, I fear we've deviated into the esoteric topic. So before we close, I just wanted to get your thoughts on how you manage this in an overhead thrower. That's certainly been one of the relative contraindications with remplissage. Do you think that's off limits, or can you do it with nuance? Tell me about your thoughts there.
Yeah, I think, again, it's a very individualized situation, and a high-level overhead thrower who has recurrent anterior shoulder instability. That's relatively uncommon, I would argue. That's a double unique issue, but they are there. They are out there. They do occur, and in those situations, for a football player, it's kind of different for me. A football quarterback, that's a different situation. I don't really worry about it very much. It's really an overhead pitcher, a pitcher, and high-level pitcher. And so for us, we really carefully evaluate our diagnostic studies. We make intraoperative EUA, and we carefully evaluate the lesions, but we will do a remplissage in those situations if we feel like we should. We don't really hesitate to do it. We might place the arm in a throwing position to tie, or may tweak it a little bit. But at the end of the day, I mean, an athlete who's putting his arm in a highly risky position, I tell our fellows, if our philosophy is that we're there to make sure the patient doesn't dislocate again, and if we lean too much into maintaining every degree of external rotation, but they redislocate, they're not going to thank you for preserving every degree of external rotation. And so even in that situation, we tend to prioritize stability over being afraid to stabilize the shoulder.
Yeah, Larry, I couldn't agree with you more. I think the football quarterbacks, I feel like they do just fine actually with the remplissage, and I think it's the difference of the weight of the ball and sort of the motion of throws. But I would say if you're a high level overhead athlete that has recurrent anterior instability, your chances honestly of having a great sort of throwing motion that is completely impeded by a stabilization of some sort, is you're already sort of at a high risk of being affected by that surgery. And so I think I would agree. I think if you start messing too much with, okay, now, I mean, we try to do the best we can to restore their motion, but I agree that I think the recurrence, if they're going to redislocate again following a surgery because you gave them too much motion, that almost leaves them in the worst position. And so, I've certainly done remplissage and throwers too, but I'm under more of the opinion that they were going to have a hard time anyways following any type of anterior stabilization procedure, getting back to their, sort of their pre-injury or pre-surgery level of competition.
Certainly, I think those are words of wisdom for the athletes and, for the gymnasts and for the volleyball players. And those are such challenging cases. Both of you guys have shared just a wealth of wisdom here on the ins and outs of the Hill-Sachs and its evaluation and treatment. And I can't tell you how much I appreciate both of your time. And this is really valuable. Listeners, I think, will really find this educational as they approach these patients. So thank you both for coming on. This was really great.
Well, thank you guys very much again for the opportunity. I've learned a great deal, as I always do, from each of you. And so thank you.
Yeah, likewise. Thanks so much for having me and for allowing me to share the podcast with Larry. What a treat, and also for kind of being able to chat with you, Brian and Peter. Just what a great venue to do it.
You guys are truly leaders in the field, and it's an engaging topic, no pun intended. And we just, I love leaning on your expertise and experience. Well, that's about all the time we have for this podcast. So just want to thank so much our two honored guests. For all our shoulder and elbow listeners out there, don't forget to subscribe. And for Peter Chalmers, I'm Brian Waterman. We'll see you next time.